A very warm welcome back, listeners, to the Irish Haematology Oncology Podcast. I'm going to throw a myriad of excuses here at you that there was a Baxter shutdown in Ireland that caused absolute havoc. My Google account was locked out for a month, so I wasn't able to access a lot of my scripts and things like that. And yeah, just didn't get around to it. But I'm back with a bang now. And so, as always, I'm your host, Eoin Tabb, and I am thrilled to have you join us today as we embark on a journey into the world of drug sequencing in cancer treatment. Now, I know what you might be thinking, drug sequencing, that does sound a bit technical, a bit dry, but trust me, it's far from it. It's a critical aspect of cancer care that can significantly impact the success of treatment and the well-being of our patients. Before we dive in, I want to extend my heartfelt gratitude to all of you who've been tuning in, sharing your feedback and spreading the word about the podcast. Your support means the world to me, and I'm committed to bringing you the latest insights and practical tips to help you navigate the complexities of oncology care. The podcast has reached over 1,000 views, listens, whatever you want to say, on Spotify, and a whole other lot of watching on YouTube as well. So, today's episode, we'll be exploring the rationale behind drug sequencing, uncovering the hidden dangers of extravasation, and discovering how clinical trials have shaped our understanding of optimal treatment protocols. We'll delve into some real-world case studies to illustrate the practical implications of drug sequencing in the lives of our patients. So grab a cuppa, find a comfy spot, and let's get started. So picture this: you're a dedicated oncology nurse, passionate about providing the best possible care to your patients. But you encounter a patient whose treatment plan involves a complex combination of multiple anti-cancer drugs. Suddenly, you're faced with a barrage of questions. Which drug should be administered first? What's the ideal interval between infusions? Are there any potential interactions to be mindful of? It's akin to being handed a treasure map without any clear instructions on how to reach the buried treasure. This is the challenge of drug sequencing in cancer treatment. It's a puzzle that can leave the most seasoned healthcare professionals pondering. We all recognise that combining different drugs can be a powerful strategy in fighting cancer. But that sequence in which these drugs are administered is equally important. It's not simply about giving the right drugs, it's about delivering them in the right order at the right time to maximise their impact and minimise those side effects. The human body is an intricate and delicate system, and cancer cells are masters of adaptation. They can evolve and develop resistance to drugs rapidly. When we administer drugs, we're essentially waging a war on multiple fronts. If we don't carefully plan our attack, we risk giving the enemy, those cancer cells, an opportunity to regroup, fortify their defences, and ultimately win the battle. The wrong sequence can lead to less effective treatment, increased side effects for the patient, and even development of drug resistance, making future treatment options even more limited. The same principles apply to drug sequencing. Each drug has its own unique properties and mechanism of action. Some drugs work best when given first, while others need to be given later in the sequence to maximize their impact. Some drugs can interact with each other, either enhancing or hindering their effects. And of course, we need to consider the patient's individual needs and sensitivities, ensuring that the treatment is as safe and tolerable as possible. So you see, drug sequencing isn't just a theoretical concept, it's a practical skill that can profoundly impact patient care. It's about understanding the nuances of each drug, the intricacies of the human body, and the ever-evolving nature of cancer. It's about using your knowledge and expertise to navigate the complexities of treatment and deliver the best possible outcomes for your patients. So, following on from that introduction and background and rationale, let's go on to the first step, that order of administration. And we're going to hit with the first one that we're going to get, and that's the monoclonal antibodies. So when administering multiple medications, including MABs, the order of administration is a key consideration. Monoclonal antibodies are often given first, particularly in the early cycles of treatment. This approach is driven by the fact that MABs are generally more likely to cause infusion-related reactions than other drugs like chemotherapy agents. By administering the MAB first, we can closely monitor the patient for any signs of an IRR. If a reaction does occur, we haven't yet introduced more potent medications into the system which could complicate the situation. So we want to build tolerance. So infusion-related reactions are most common during the initial cycles of MAB therapy. To minimize this risk, the first infusion is typically given at a slower rate. This allows the patient's body to gradually acclimatize to the MAB, reducing the likelihood of a severe reaction. As treatment progresses and the patient demonstrates tolerance, the infusion rate can be gradually increased. This slow and steady approach helps build the patient's tolerance to the MAB, making subsequent infusions smoother and safer. Remember, go back to that infusion-related reaction episode that we recorded earlier, and in that you'll learn all about the tools and concepts of infusion-related reactions and how to manage those using pre-medications and those rates as well. So now we need to identify the culprit, pinpointing that infusion-related reaction agent. In some cases, patients might receive multiple MABs or other medications during an infusion session. If an IRR occurs, it's crucial to identify the specific agent responsible. This knowledge helps guide future treatment decisions and ensure patient safety. To pinpoint the culprit, healthcare providers will carefully consider factors like the order of administration. So as we discussed, MABs are often given first due to their higher IRR potential. The timing of the reaction. So IRRs typically occur within a specific time frame after the start of infusion, maybe an hour to 4 hours after, within an hour to 4 hours afterwards. And the patient's medical history. Previous reactions to specific medications can offer valuable clues. So have they had a reaction before to that agent? So that's the reason why we give monoclonal antibodies first. It's to prevent and identify those infusion-related reactions. All right, let's shift gears now and talk about another critical aspect of drug sequencing, the careful handling of vesicants. And this is a follow-up from our episode last week on chemotherapy extravasation. And it was the idea from that episode that put this idea of chemotherapy and the SACT drug sequencing into my mind. So for those of you who might have missed that last episode, please go back. Well, I'll give you a quick brief overview now here. So vesicants are a special class of drugs that can be a bit like handling a live wire. If they accidentally leak out of the vein during administration, a phenomenon we call extravasation, they can wreak havoc on the surrounding tissues, causing severe pain, inflammation, and even necrosis or tissue death. So imagine this, you're administering chemotherapy to a patient and suddenly you notice swelling and redness around the IV site. The patient complains of burning pain and you realize with a sinking feeling that that vesicant drug has infiltrated into the surrounding tissue. It's a nightmare scenario for any nurse and the consequences for the patient can be devastating. Extravasation can lead to long-term complications such as scarring, nerve damage, and even limb loss in severe cases. It's a stark reminder of the delicate balance between the life-saving potential of cancer drugs and their inherent risks. Thankfully, the Morales Guide provides a clear roadmap for navigating the treacherous waters of vesicant administration. It's all about minimizing the risk of extravasation through careful planning, meticulous technique, and vigilant monitoring. Think of it like defusing a bomb. Every step needs to be executed with precision and focus to avoid a catastrophic outcome. One of the key strategies outlined in the guide is prioritizing the administration of vesicant drugs. This means giving them first in the sequence if there isn't a MAB in the regimen. So for the likes of R-CHOP, you're giving your Ritux first, followed by your vesicant drugs. So your doxorubicin next, and so on. By administering vesicants early on, we increase the chances of detecting and managing extravasation promptly before significant damage occurs. It's about staying one step ahead of the game, anticipating potential problems, and being prepared to act swiftly. We also want to make sure that the patient's veins have the best patency at that time, so that they're at their strongest. So you want to give those drugs which can cause leakage into the veins when the veins are at their strongest, so before the majority of other medications have been given to that patient. If you want to learn more about the important aspects of managing chemotherapy extravasation, be sure to check out the previous episode on the topic. And guess what? I'm going to share a super helpful mnemonic in this episode that I totally forgot to include in the last one. So to help you remember the key principles of vesicant management, let's use a handy mnemonic, VIP access. So V, vesicants first, prioritize the administration of vesicant drugs. IV access, choose the appropriate vascular access device. P, precise technique, employ meticulous administration technique. A is for assess and monitor, vigilantly monitor the patient and IV site. C is for cold or warm compress, apply appropriate compress if extravasation occurs. C is for call for help, don't hesitate to seek assistance if needed. E is for educate the patient, empower the patient to recognize and report any concerns. And S is stay calm and collected, maintain composure, and act swiftly in the case of extravasation. Go back and look at those SOPs and apply antidotes if required. So now we're going to go on to the order of administration as determined by clinical trials and the optimization of clinical effectiveness. Now let's shift our focus again to another fascinating aspect of drug sequencing, the pivotal role of clinical trials in determining the optimal order of administration. Clinical trials, as you know, are the gold standard for evaluating the safety and efficacy of new treatments. They involve carefully designed studies where patients are randomly assigned to different treatment groups, allowing researchers to compare the outcomes and identify the most effective approaches. And when it comes to drug sequencing, clinical trials have revealed some truly remarkable insights. So think of those clinical trials as a grand experiment where scientists meticulously test different combinations and sequences of drugs to uncover the hidden synergies and antagonisms that can make or break a treatment plan. It's like a chef experimenting with different ingredients and cooking techniques to create the perfect recipe. Sometimes the results are surprising and unexpected, leading to breakthroughs that can transform the landscape of cancer therapy. Other times, the results confirm our existing knowledge, providing further evidence for the importance of drug sequencing. One of the key takeaways from clinical trials is that the order of drug administration can significantly impact treatment outcomes. It's not just about giving the right drugs, it's about giving them in the right order at the right time to achieve the maximum therapeutic effect. For example, in certain types of leukemia, studies have shown that administering a targeted therapy before chemotherapy can prime the cancer cells, making them more vulnerable to the subsequent chemotherapy attack. It's like softening up the enemy's defenses before launching the main assault. This strategic sequencing can lead to improved response rates, longer remission times, and ultimately better chances of survival. Think of the likes of Ritux or Obin-Benda in CLL. But the benefits of optimal drug sequencing go beyond just improving efficacy. It can also help to minimize the effects and improve the patient's quality of life. In some cases, changing the order of drug administration can reduce the severity of nausea, fatigue, and other common side effects of cancer treatment. It's like finding a smoother route on a bumpy road, making the journey more comfortable for the patient. This can have a profound impact on their overall well-being, allowing them to tolerate treatment better and stay on track with their therapy. Now, I know what you're thinking, this all sounds great, Eoin, but how do we keep track of all these different sequencing recommendations? It's enough to make your head spin. Well, that's where the Morales guide comes in, and other resources like the chemotherapy sequencing chart come in handy. All of these will be added to the show notes below. They provide a comprehensive overview of evidence-based sequencing recommendations for a wide range of cancer types and treatment regimens. The guides are organized in a user-friendly format, making it easy to find the information you need quickly and efficiently. They also include helpful tips and mnemonics to aid in memorization and implementation. Now, this guide is for your own knowledge only. The NCCP have done a wonderful job, and many of the other organizations who develop treatment protocols or regimens have done a wonderful job in already denoting that order of administration for you. But for your own knowledge, instead of haphazardly just putting things in, following a regimen without the knowledge, for your own knowledge and education, it's great to look at this guide and see why NCCP and the likes have chosen this order of administration for the drugs. So let's look at a couple of examples here of how clinical trials have informed drug sequencing recommendations. In the treatment of colorectal cancer, the FOLFOX regimen, which consists of 5-fluorouracil, 5-FU, leucovorin, or folinic acid, and oxaliplatin. That has been a mainstay for colorectal cancer treatment for many years. But recent studies have shown that the order of administration can significantly impact its effectiveness. The current recommendation is to administer oxaliplatin and leucovorin together, followed by a bolus of 5-FU and then a continuous infusion of 5-FU over 46 hours. This sequence has been shown to improve response rates and reduce side effects compared to other sequences. If you look at that one there, oxaliplatin is the most likely to cause nausea and vomiting out of those agents. It is moderately emetogenic, whereas 5-FU has a low emetogenic potential. Thus, you're giving your pre-medications for nausea and vomiting 30 to 60 minutes before administering the oxaliplatin and giving that up front. So thereby you're minimizing the effect of that risk of acute nausea and vomiting at that area. Another example comes from the world of immunotherapy, a rapidly evolving field that harnesses the power of the immune system to fight cancer. In the treatment of melanoma, a type of skin cancer, the combination of ipilimumab and nivolumab has shown remarkable success. However, studies have also revealed that the order of administration matters. Administering ipilimumab before nivolumab has been associated with improved response rates and survival compared to the reverse sequence. It's like priming the immune system with ipilimumab before unleashing the full force of nivolumab, leading to a more potent and sustained anti-cancer response. These are just a few examples of how clinical trials have shaped our understanding of drug sequencing and its impact on cancer treatment. So next time you're faced with a complex treatment plan involving multiple drugs, remember the power of drug sequencing. Consult those available guides. If you want to deviate away from that treatment protocol, consult the available guides and tap into the wisdom of your colleagues as well to devise the optimal sequence for your patient. Maybe there's a reason why your patient doesn't want it in that order. Can you give it in another order? Has stuff arrived over from the pharmacy in the incorrect order of administration? Can you give it in the order that it's arrived in, or should you hold off for that delivery of the rituximab or the mab first? So use these guides as your guide to deciding as to which order of treatment is appropriate for that patient. We're going to go through a couple of more nitty-gritty real-world case studies as well. So first of all, let's go to the haematology ward. We have a patient newly diagnosed with acute myeloid leukemia, AML. It's a formidable foe that demands a swift and strategic response. The treatment plan calls for a combination of cytarabine and daunorubicin, two heavy hitters in the chemotherapy arsenal. Cytarabine disrupts DNA synthesis, while daunorubicin goes straight for the DNA itself, causing breaks and fragmentation. Both are vital for tackling AML, but daunorubicin comes with a catch. It's a vesicant. If it leaks out of the vein, it can cause severe tissue damage. So what's the optimal sequence here? So go back to what we said here. It recommends administering daunorubicin first, followed by cytarabine. Why? Because by giving the vesicant daunorubicin first, we're essentially tackling the most volatile element early on when our vigilance at its peak and our veins are at their most patent. If any extravasation occurs, we're more likely to catch it quickly and take immediate action to minimize the damage. And your veins are at their strongest. So let's go over to the oncology clinic where we meet a patient with breast cancer. Her treatment plan includes a combination of 3 chemotherapy drugs: docetaxel, cyclophosphamide, and doxorubicin, often referred to as the TAC regimen. This trio is like a well-coordinated team, each with its own unique role to play. Docetaxel targets microtubules, essentials for cell division. Cyclophosphamide interferes with DNA replication. And doxorubicin, another vesicant, attacks the DNA itself, causing breaks and damage. The order in which this operates is crucial. So how do we sequence these drugs to achieve the best possible outcomes for our patients? Well, once again, the Morales guide comes to the rescue. We recommend a specific order: doxorubicin first, followed by cyclophosphamide, and then docetaxel 1 hour later. This sequence isn't arbitrary. It's based on years of clinical trials and research demonstrating improved response rates and reduced side effects compared to other sequences. So these case studies are just a glimpse into the vast and intricate world of drug sequencing. They highlight the importance of evidence-based decision-making, the power of clinical trials, and the clinical role that nurses play in optimizing cancer treatment. By understanding the nuances of drug treatment, by understanding the nuances of drug sequencing, you can become a true advocate for your patients, ensuring that they receive the most effective and safest care possible. It's about going beyond the textbook knowledge and applying your clinical expertise to create personalized treatment plans that can make a real difference in the lives of those battling cancer. So as we wrap up today's episode, let's take a moment to reflect on that impact of drug sequencing can have on cancer treatment. It's not just about administering medications. It's about empowering ourselves as healthcare professionals to deliver the best possible care to our patients, helping them navigate the complexities of cancer treatment and emerge victorious on the other side. Thank you for tuning in to the Irish Haematology Oncology Podcast. As always, please check out the show notes below for those guides, as I said. There will be a CPD document, example document for pharmacists to do. And there is a feedback form. Please provide me with any feedback or leave comments in on Spotify or YouTube or whatever, and I'll catch them. You can also catch us on Instagram, where I post up a couple of clips from the podcast at Irish Haem Pod, and you can email me as well on irishhaemoncpodcast@gmail.com. Thanks a million, guys, for all. So until next time, catch you later. Sorry, and as always, I end this podcast with this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer care is always advancing, and new research may lead to changes in treatment approaches or protocols. Always consult with your own team for personalized guidance and discuss any information with this podcast with them. Seek information from trusted local and national resources for the most up-to-date recommendations. All right, now, see you later.